way around and then document where it hurts. Okay. The next step is to feel the pelvic floor. So this is just a gloved finger, one finger goes inside, and we're going to start feeling for the muscles. And why do we feel for the muscles? The muscles are basically, the pelvic floor muscles are a support system. So they help support all parts of the pelvis. So urologists are much more familiar with the pelvic floor sometimes than gynecologists, but it helps support everything. And it's really important in the female sexual response. So sensation is going to be strongly related to the pelvic floor muscles, and orgasm is actually located in the pelvic floor. So when people have orgasms, it's the pelvic floor that's contracting. And if the pelvic floor is too weak, then people can have sexual problems, and if it's overactive and too strong, people can have sexual problems as well. So I think of the pelvis is like a bowl, right? So it's a bowl and it's lined by muscle. That's how I explain it to my patients. And these are the muscles we're feeling for. So we're in the vagina, and if you go deep inside, the first muscle you're going to feel is the levator ani, and it feels like a pretty thick band, all right? And then if you go further in, you're going to feel the coccygeus muscle, and even further in is the piriformis. On the lateral aspect, so I kind of sweep my finger up, I can start to feel the obturator internus. And those are the muscles that oftentimes you're going to find problems in when somebody has sexual pain that's due to the pelvic floor being the cause. Now there are superficial muscles too, and we see these get damaged a lot during obstetric injuries especially. And the superficial muscles to know about are the bulbocavernosus and the bulbospongiosus, which basically wraps around the vagina, all right? And then there's the transverse perineal. And you can actually feel these from doing an external exam. So you're going to feel around the labia, down past the perineum, and you can feel for tenderness there as well. So what is pelvic floor dysfunction? And basically it's when the muscles, I always explain it like if you exercise too much and you pull a muscle in your shoulder, it hurts when you touch it, right? And it's the same thing that happens in these muscles. And the first thing you'll notice on exam is it hurts to touch. And so when you're pressing on it, you'll see that kind of pain. When people have vulvar pain, right, so it's external pain, they can still have pelvic floor dysfunction. And sometimes the pelvic floor causes the external pain, and other times the external pain from the vestibule, when people are clenching their muscles so much because it hurts every time they try to have sex, they start to get really high tone pain in the pelvic floor. And it can feel like a burning or a tearing sensation. It can cause urinary symptoms. So a lot of these patients will have an overactive bladder because the muscles are really tense and it's overacting. A lot of them will have constipation because they're just really tense all the time, or the constipation and the constant squeezing caused the pelvic floor dysfunction. And one thing that I think is really important is to know that we used to call this term vaginismus. Who here has heard of the term vaginismus? So in where I'm from, so some people have heard of it. Historically, anybody with sexual pain was told that they had vaginismus. But vaginismus is a very specific diagnosis. So vaginismus was in the DSM-4. It is no longer considered a diagnosis, even though, well, in the DSM-5. But in sexual medicine, we still use the term. But it is a very specific clinical syndrome, and it's basically when there's an involuntary spasm in the musculature of the outer third of the vagina. So basically the vagina just closes. And people describe it where it feels like they're trying to hit a wall. They're trying to put a penis inside, and it's just hitting a wall. It just won't go in. But it doesn't hurt as much as something like pelvic floor dysfunction. So the pelvic floor muscles, when someone has vaginismus, they don't usually hurt significantly when you press them. You just can't get inside. And I see that a lot in patients who are raised in very sexually conservative cultures and societies, where they just are kind of raised to think of closing those muscles from a very early age. All right. Okay. So then the other thing I want to talk about is primary versus secondary provoked vestibulodynia. Actually this came a little bit early, but this is just basically when the vestibule is the source of pain. So remember in the first and second patient, the first patient had a primary provoked vestibulodynia, so she could never put anything inside. And then the second patient, it was secondary, so it came on later. And this is just a little bit on the science behind it. It actually looks like when somebody acquires vestibulodynia, it's more of an inflammatory response. So we sometimes see it related to an infection, like a yeast infection or a BV. And then people who are born with vestibulodynia, they never could put anything inside because the tissue on the outside hurts. It's probably more of a nerve problem where there's just too many nerves. And I'll talk about that a little bit more when we get back to the cases. All right, so when it comes down to the pelvic floor, what you're looking for is tenderness, and you're going to be feeling each muscle and saying, does this hurt? And ask if it mimics her pain. So I have seen patients who tell me, oh, it's my ovary is the source of my pain. But then when I press on the muscles, they're like, that's the pain. And that's because it was the muscle that was the problem. Most people are going to say it doesn't feel good to press the muscles. That's normal, it's uncomfortable, but it should not hurt. And I do so many of these exams that I always get reassured when I see someone that doesn't have pain, because it reminds me, oh, this is normal. It shouldn't hurt. It just might be a little bit uncomfortable. Okay, what about higher up? So cervicitis, sometimes people say, oh, if they have sexual pain, they have pelvic inflammatory disease. So if you're touching the cervix and the cervix really hurts, you could think, oh, could this be pelvic inflammatory disease? But remember, pelvic inflammatory disease is a diagnosis of exclusion, right? So it's not, we know that it's not another problem that's causing their pain. But if they have significant tenderness on the cervix, and they have a fever or abdominal pain or leukorrhea, so white as your inflammatory discharge, then you could be worried. But most people, obviously, with chronic sexual pain, it probably is not PID. What about endometriosis? Someone asked, our really wonderful, participant who's been really active today asked about endometriosis. So endometriosis and sexual pain go together, but the pain is quite specific. So chronic pelvic pain in the pelvis is quite common with endometriosis, and anybody with chronic pain is probably going to have less sex. They're going to avoid having sex. It's going to affect their relationships. But the pain with endometriosis is very specific to deep infiltrating endometriosis when it's on the uterosacral ligaments. So it's the space in the back of the uterus. I can't see my phone here now. It's not going all the way over there. Oh, no, here it is. So in the back of the uterus, down here is the uterosacral ligaments. It's what provides support to the uterus. When endometriosis is there, that's when it hurts. And the reason it hurts is because the endometriosis, it's both an inflammatory process, but it also causes nerves to grow in. And that's why, even if it's a tiny speck of endometriosis, it can cause significant pain because there's nerves that we can't see when we look in that have grown into it and cause pain. And so when they're having sex, if the cervix is getting hit, it's pulling on the uterosacral ligaments and causing pain. And there's a cycle of pain that's related to inflammation, prostaglandin release, and nerves that cause it. Now, if you suspect endometriosis, the pain from sex should be deep, right? That's that deep thrusting pain positions where they go really far inside. If you're going to treat endometriosis for anybody that's in gynecology, it's very related to what their goals are in terms of pregnancy. We do surgery to diagnose endometriosis, but it does not cure it. Endometriosis will come back. So you have to manage it with medications, including pain medications and hormones. So these are all the ones we use. We use NSAIDs to help with pain, combined hormonal contraception, so like birth control pills, Depo-Provera, the levonorgestrel IUD, Nexplanon, Lupron, Elagolix, immunomodulators, and anti-angiogenic agents. These are kind of newer ones. The most common thing that treats endometriosis is birth control because it suppresses endometrial growth. Not in everybody. It's actually very interesting. Endometriosis doesn't respond the way that normal endometrium does to hormones. And that's why up to a third of women just don't get better even though we give them all these hormones. So I hope that addresses this question of endometriosis. Now, one thing to know about endometriosis is that if someone has chronic pain from endometriosis, they oftentimes will get pelvic floor dysfunction. So they're squeezing, they're in pain, so we might be able to cure the endo, we can do surgery to take it out, we give them hormones, but the muscles now need to be treated. So you need to have a multimodal approach. Okay. So let's get back to the vestibule. So remember I said the vestibule is really where we see a very significant portion of sexual pain. And this is the ISSWISH and the International Society for Vulvovaginal Diseases. They have classifications for vulvar pain. These are all the things that can cause vulvar pain. So it can be infectious like herpes or a recurrent yeast infection. It can be inflammatory like a dermatosis. It can be a cancer. I don't know, who here has seen Paget's disease? So Paget's disease I just diagnosed for the first time. I've been in practice for about 12 years, and I saw Paget's disease when I worked with the oncologists, but I never had diagnosed it myself in a general clinic. And I saw a woman recently who kept being treated for yeast infections. And when I saw her skin, it looked to me like it was lichen simplex chronicus. It was white and lichenoid, but it was really just weepy, kind of draining fluid. It did not look normal, so I did a biopsy and it was Paget's disease. So if you ever see very strange looking skin, obviously do a biopsy. Some people have pain from genital cutting or obstetrical pain, right? So they have a laceration during a delivery. And then obviously things we give patients can cause vestibular pain. So anything that induces menopause is going to cause genitourinary syndrome of menopause. But even breastfeeding can lead to the decrease in hormones and can lead to really sensitive tissue. And then if we have no idea, we ruled out all those things and it's just pain, that's when we call it pure vulvodynia. So now let's get back to some of these rare patients. So this is that patient who could never place anything inside, okay? So for her, when we actually look closer, we find out that she has what's called primary provoked vestibulodynia or neuroproliferative vestibulodynia. Sometimes you can't even find anything on exam. It looks normal, but when you touch it, they tell you, oh my God, that burn is so sharp, you can't get anywhere. And if you did a biopsy, you would actually see that there's significant increase in the density and the thickness of the nerves. All right, so I talked about, sorry, the slide got in there before. This is the difference between the first and the second primary provoked. So if they're born with it versus if they acquire it. But the treatment is going to be the same either way, basically. So even for those who have this kind of neuroproliferative, it kind of could be from inflammation or from the nerves, we're going to start treating it with nerve medication. So the first one we sometimes use is a tricyclic antidepressant, so something like amitriptyline, or anticonvulsants, something like gabapentin. These are common medications. The data is limited. There was one study that was a randomized trial of gabapentin versus placebo, and it did not show a benefit. But what I tell people is, these are large groups of women, so hundreds of women. There were some women who did get a benefit. And in the absence of having good treatments, I also give them something. And there are some women who really do get these pills. There was a randomized controlled trial that showed amitriptyline, tricyclic, and using lidocaine. So some people will use lidocaine to help numb the tissue. Lidocaine doesn't necessarily make the pain go away long term, but it can help when people are trying to have sex to decrease it. So the descriptive studies for topical treatments like lidocaine, the best place to see it is when it's pain related to GSM in breast cancer patients. So for breast cancer patients who may be scared of using hormones, what I will tell you is that use hormones. In breast cancer, they can use low-dose hormones, but if they want to, they can use a lidocaine and they can just place it on the entrance. The other medications that we use, we compound medications. So in Vietnam, are you able to compound medications when you go to a pharmacy and say, make me a combination of medication? Have you seen, like, some people, maybe not? Okay, so these are some of the medications that we use. So capsaicin is one of them. Gabapentin, we can make it into a cream. And then there's a role for Botox, botulinum toxin. And sometimes we use things like ketamine or other types of compounds. So we can compound them. But if you don't have access to that here, then I would try the oral medications. If nothing works, for these patients, we actually will sometimes do a vestibulectomy. And a vestibulectomy is where we actually cut the tissue. And we do a very thin, and we make it's about 2 to 3 millimeters in depth. And we literally just go around. I usually go up past the urethra, past the skin glands, and I make this horseshoe-shaped incision. And the incision goes all the way around, and we basically then sew the healthy tissue back together. We go from heart's line to the hymen, because the pain really starts at the hymen, and we just excise it, a very thin layer of tissue. And I promise you, it heals beautifully. So this is the kind of surgery where they would never notice, their partner would never notice. If they get married, nobody would say, oh, you don't have a normal looking vagina. It heals really well, and the data shows that it works very well also. So this is a surgery that we sometimes do. Now, some people, if they're not going to get a vestibulectomy, they want to try something like injections. That's where we do things like Botox. And so the Botox that we use, we actually will put it for the superficial, we put it in the superficial muscles, the lobar cavernosus, and we basically just put like small, tiny injections all the way around. You want to do like just 10 to 20 units in each location. And this has been shown in several studies to have some benefit, but the data is mixed, and it's probably because the dosages vary. So I usually will use about 100 units when it's just for vestibulodynia. And we'll talk a little bit about using Botox in the pelvic floor, because that's where there's actually more data and probably more of a benefit. So I'm just going to skip through some of my slides. Looks like they got a little messed up a little bit. I'm going to go back to just say for the vestibulectomy, if you want to see the best resource for this is an article in the American Journal of OBGYN. That was published in 2019, and it shows this kind of horseshoe-shaped incision. And this study, if you can access it, really goes through kind of step-by-step how to do this. So, this is the kind of surgery that I will say don't try it on your own, but I'll be honest that I went to so many conferences and we talked about the surgery so much that I decided to just start doing it on my own, because I was like, this cannot be that hard. And I've had really good success from doing it. The main thing is if you're, for urologists, you're very comfortable being near the urethra, but for gynecologists, we're not. So I'm very scared when I get near the urethra, and I just want to make sure I have to get very close to it, but I don't want to get too close because I don't want to damage it. So I'm constantly checking to make sure that I know where I am. One of the key things about doing the surgery is when you take out the tissue, we want to then bring the vagina forward. And anyone who does a posterior repair knows how to undermine, right? You hold the vagina and then you just undermine it bluntly and make it loose, and you're basically attaching the posterior vagina to the perineum. And so that's kind of the key thing here. And we do this with, we put mattress sutures in with 2O Vicryl, and then we close the external tissue with 4O Vicryl or monocryl. in interrupted stitches, just one after another, after another, after another. I want no gaps between the tissue. I want everything to close. After the surgery, they have to keep their legs really close together for about 2 weeks. And then they have to not put anything inside for another 4 weeks. So it's about a 6-week recovery. And so I just tell them to do very limited activity. And after the 6 weeks, it's very important if they have access to a physical therapist or dilators to start putting things inside so that it doesn't scar down, that you have to basically help try to keep the tissue open. So this is just for some patients, this is a very interesting surgery that we do. I'm not here to tell you to go out and do it, but it is out there and an option for some patients. If they have that specific type of vestibulodynia where they're born with it and it's a nerve problem. So that's different than our second patient, right? So this is our second patient who basically has been on birth control pills for a very long time and is now having a gradual increase in her pain. And she's somebody that when you do her exam, what you see is that there's redness all over the vestibule. So it looks very red. It's worse at the vestibular glands, at the Skene's glands and the Bartholin's glands. And she has what we call hormone-mediated vestibulodynia. So these are people that have been taking birth control pills for a long time, and the birth control has altered the way that the hormones work in their body. And it can be very concerning because the question is, well, did the birth control do this? And in some patients, it actually does. There's multiple case control studies that show that there are women who take these pills, and most likely we think that it could be related to the testosterone receptors because all birth control lowers testosterone. And we've learned today that there are androgen receptors in the vulva. So it's probably the low testosterone that causes what looks like almost like a menopausal response. So if we think that that is the cause, then you want to switch to a different type of birth control. Obviously, you want it to be effective, and then we use local hormones. Now, I will compound, I'll go to a specialty pharmacy, and I will compound a high-dose estrogen and testosterone. But here, if you don't have access to it, you could just prescribe vaginal estrogen. Give them get them off the birth control, give them something else. So an IUD doesn't do this. Progesterone-only pills don't do this. This is very specific to things like Depo-Provera and things that have ethinyl estradiol, like the birth control pills or the vaginal ring. The main thing is don't miss the diagnosis if it's something else. And I always say this because I had a young woman early on in my practice who was told that she had this condition. And so they put her on estrogen and they gave her different birth control, but she actually had lichen sclerosis. And it was missed for many years. And so always do an exam and try not to miss things like that, which we may be more familiar with. Okay, our last patient, so she's the one, remember, who had a hysterectomy and then noticed the pain a few months later and thinks something went wrong with the surgery. And she's somebody who has mild genitourinary syndrome of menopause, mild vulvovaginal atrophy, but that's not the cause. No tenderness on her Q-tip exam. Her incision in her vagina was healed very well, so it doesn't appear that the surgery site is the cause of her pain, but she has pain over her pelvic floor muscles. And so she has high tone pelvic floor dysfunction. And it is likely that the surgery pulled on those muscles and so caused some damage from the surgery. And this could be from a surgery, or you could see this in somebody who's premenopausal, who had a vaginal delivery. Many things can cause pelvic floor dysfunction. So what are the treatment options? The best treatment seems to be physical therapy if you have access. So there was a recent paper that was put together with a clinical algorithm. It was published by a bunch of urogynecologists mainly, and they said the first line is physical therapy, so people will do dilators, they do what's called biofeedback, where they learn kind of how to train their brain to respond differently. But there's no real good data on anything because there's a lot of heterogeneity in our patients. You can do pelvic floor injections, and this is where I think there's a lot of benefit. So for pelvic floor injections, I use a pudendal kit. So we're used to using this, we will sometimes numb the pudendal nerve. It's a long trumpet to protect the needle. And you can actually inject into the muscles that hurt. You can either use something like lidocaine, which I'm sure you have access to. I'll oftentimes add triamcinolone, usually about 10 milligrams of triamcinolone. And then if I have access to Botox, which is very expensive, and in the United States it's not covered by insurance, you can also use Botox, and there's good data there. But if you don't have access to Botox, you really can just numb the muscles and then add a steroid, and it really makes a difference. And it certainly makes a difference for vaginismus as well. So you can do that for vaginismus as well as for high-tone pelvic floor dysfunction. So my final thoughts for this talk are that there's no single treatment that's ideal. Whenever you're doing sexual health, anything, for sexual pain, you want to do a thorough physical exam, and always keep the biopsychosocial model in mind. So I can determine what the cause of the pain is. But if someone's had pain for a long time, as a medical doctor, I can give them medications, I can do injections, I can do surgery. But I always take a step back and say there's oftentimes going to be a psychological component and then obviously a social component, right? Something that might be wrong in their relationship. And I don't want to ignore that either. But I think that so we can just make sure we're taking care of the whole person. But I hope that today I left you with some tools in your toolbox to help these patients, because I think obviously this is very common. And I'm happy to answer questions about sexual pain if you have any. Thank you.
Okay.
One second. They gave me water.
Yeah, thank you for this presentation. Tôi xin giới thiệu tôi là bác sĩ Thông Quỳnh Tập, để viêm mũi sàn ở địa phương Minh. Thì tôi có đang đến cái lĩnh vực là hiếm muộn, cho nên gặp rất nhiều cái tình huống giống khi mấy cái case cô này đưa ra, tức là có những cái ca họ cưới nhau 1 năm, thậm chí là 5 năm, có ca nhiều nhất tôi gặp là 7 năm, họ không hề giờ học, tại vì nó có thắt âm đạo, cái và không cho họ được lần nào hết, họ có con, và đến giống như tình huống đó là họ mong muốn có con. Phụ nữ Việt Nam mình có rất nhiều ca rồi nhưng họ không đi khám, họ ngại, họ không đi khám, tức là không cho họ được con khám. Đến khi nó áp lực gia đình có con họ mới đi khám. Thì lúc này đặt ra vấn đề là bây giờ làm sao để điều trị cho họ để họ có thể cho họ được có thai. Và rõ ràng tất cả nghiên cứu cô đưa ra thì cái data đưa ra là gần như không có cải thiện. Vậy thì cuối cùng là mình cố gắng làm sao cho họ có thai. Thì khi đó là mình lựa chọn giữa là bơm tinh trùng vào âm đạo hoặc là IVF, thì tôi xin lựa chọn là IVF. Và kinh nghiệm tôi thấy là sau khi làm IVF đó, lúc mà mình chọn trứng á, thì thay vì cô này có dùng thuốc là protein hay tức là ức chế thanh thần kinh, thì bây giờ người ta dùng thuốc mê lên để mặt để mình chọn trứng, thì lúc đó chúng ta ngủ. Thì nó giống như là cái testiculostomy của người ta đó, thì mình không có làm cái đó, nhưng mà mình dùng cái mỏ dịch của mình ta nâng rộng âm đạo ra. Trong lúc nâng rộng âm đạo ra thì sau đó thì cô này bộ có thể bắt đầu có thể học được một số ca nhận được, một số ca chưa nhận được thì sau đó những cái lần mình xoăn á, thì lúc đầu mình xoăn nãy thì mình xoăn ngay trên tràng, sau đó mình xoăn ngay âm đạo, mình nâng từ từ ra, và cuối cùng là gần như tất cả 100% các ca đều có thể học được. Thì đó là cái kinh nghiệm chia sẻ. Vậy thì bây giờ nếu như mà mình không làm cái chuyện đó, không nâng ra, thì liệu rằng thì nếu như những trường hợp đó cô này cũng muốn họ có thai thì họ sẽ làm thế nào? Câu hỏi đặt ra là nãy cái tình huống case one là có là họ không muốn có con, thì nếu như cô này dùng phương pháp nào để họ có con được thì chia sẻ cho họ.
Thank you for sharing. So I see these types of patients very frequently, and one of the things that I always try to reassure people about, because they're very, very anxious very stressed, right? I want to get pregnant. The sex is, they're not even talking about I want to feel good from sex. It's I just want to get pregnant. So my approach is a little bit different. I think the IVF and going in and taking them to the operating room and opening things up is very useful. But what I typically do is I just give them a bunch of sterile syringes from the office and then some urine cups. And I just say, track your menstrual cycle. In the middle of your cycle, have your partner ejaculate into a cup, pull up the syringe, get it as close to your vagina as possible. And I have helped so many people get pregnant that way. And then the pressure is relieved, right? And then oftentimes we then worry about what's going to happen in the delivery, further on. But they oftentimes have a lot more relaxation during pregnancy. And certainly if they have a vaginal delivery, it opens everything up. And so it's both a physical release, but also the mental release of now they're pregnant. So I think if we're doing the same thing, I just do it a little low tech. Other questions?
Dạ vâng, em cũng xin chia sẻ anh ca lâm thứ hai thì đúng là trường hợp anh chia sẻ em cũng đã gặp trường hợp năm 2014. Hồi đó em làm phòng khám lai ở 26 Phi Tòa thì em làm nam khoa thì chị bác sĩ Vân có ngồi đây thôi, có cái khám sản. Bác cứ lên mượn cái mô hình dương vật xuống để long trong một cái trường hợp ca bệnh mà bạn ấy với chồng sau đó quan hệ đau không dám cho quan hệ. Và khi đến khám thì bác sĩ Vân khám thì long bằng cái dụng cụ vật mô hình dương vật thì nó to hơn dương vật bình thường rất là nhiều, nhưng mà khách hàng không đau. Và sau đó thì tư vấn tâm lý thì về bạn dần dần bạn quan hệ được, có nghĩa là cái vấn đề tâm lý là rất là nhiều. Thì em cũng có một cái câu hỏi thứ hai, câu đấy là đồng cảm với anh đã từng câu hỏi đấy. Câu hỏi thứ hai là em muốn hỏi cô là cái trường hợp mà đau do co thắt 1/3 ngoài âm đạo nó có khác gì so với cái co thắt sàn chậu khi phụ nữ đặt cái cảm hay không?
So if someone has pain in their clitoris, is it a different type of pain? So clitoral pain is very interesting because clitoral pain can be from a number of different causes. So it can be from the muscles. A pelvic floor dysfunction can cause clitoral pain. Clitoral pain can also be related to the clitoral hood getting stuck, almost like a phimosis that we see in the penis, where people with more uncircumcised get a phimosis. So we see that in the clitoris as well. Clitoral pain can also be related to the pudendal nerve. And so the pudendal nerve runs, from the spinal cord through the pelvis through Alcock's canal. So that can be the cause. And it can also be due to like a spinal problem, can cause clitoral pain. So it's very different. And it's kind of its own. I can give a whole talk on clitoral pain. It can be very frustrating, actually, to treat it. But usually if someone has clitoral pain, I have to figure out, is it coming from the skin? Is it coming from the dorsal clitoral nerve? Is it coming from the muscles? Is it coming from the pudendal nerve? Or is it coming from the spine? And it could be any of those. And so I'm kind of doing different tests to see if I can find that diagnosis. I hope that answers your question. But it's very different than the vestibular pain. In the vestibular pain, I'm very clear. It's either a skin issue, so the nerves, the neuroproliferative. It's a hormone issue. It's all those different things that we discussed, or it's the muscles in the pelvic floor. That's almost always what you're going to be able to find. But the clitoris is a little bit trickier. Another question?
I have a question. Tôi là nhà hiệu khoa, tôi là bác sĩ tiết niệu. Tôi hỏi một câu, vừa rồi là bà có nói vấn đề là khi mà điều trị đau ấy, thì có phẫu thuật cắt một phần âm hộ và âm đạo để điều trị đau. Thì cái này thì tôi cũng đã làm cái phẫu thuật đó, nhưng phẫu thuật đấy là làm co nhỏ đạo thôi. Thế thì bây giờ trong cái phẫu thuật của bà điều trị đau này thì đánh giá như thế nào để cắt bao nhiêu cho đủ để xác định địa điểm đau ở đâu để cắt đến đâu cho đủ? Đấy câu hỏi rồi.
So the translator is saying the word clitoris, but I think you mean the vestibule. I don't think you're cutting the clitoris. So if you're going to cut the tissue, I always want to be very clear about the diagnosis. If the pain is very, if it's a very narrow area of pain, very local area of pain, I don't usually cut out that area. Oftentimes, what we find is that it's like in the back of the vagina, that it could be from the muscles, or it's like one small piece of tissue. What I actually do in my practice, instead of cutting that area, I inject it with a steroid to decrease inflammation, and I get success that way. And then one thing that I also think sometimes happens is if it's from the hormones, I have seen sometimes my colleagues will cut the tissue without realizing, oh, this was actually the hormones, and so you treat it with hormones. So typically, I try to give people topical treatments first with hormones, and then sometimes with the compounded medications. Sometimes I do injections. I basically try to do everything I can before I start cutting their tissue. But if you're going to be cutting their tissue, you only want to be cutting the area that hurts, and reattaching areas that don't hurt. And you only want to be taking a couple millimeters. So that would be my recommendation. But as a surgeon, I love to operate, but I always tell people my goal is to try to get people not to get surgery, because it obviously carries more risk.
Xin một câu hỏi với bác giáo viên. Cái phương pháp mà cắt bỏ tiền đình căn hộ đó thì ở cái tại điều trị của bà này là theo thầy của bác sĩ nội khoa hay là bác sĩ phụ khoa, và cái thứ hai nữa là khi mà chúng ta cắt tiền căn hộ liệu rằng là chúng ta có thể là gây ra một cái sẹo hoặc là một cái co nhỏ ở cái vùng tiền đình như vậy, thì mình làm cho một cái đau này là chỉ đến một cái đau khác là do cái có thể là cái sẹo xấu hoặc là một cái làm cho co nhỏ cái vùng âm đạo, thì liệu rằng như vậy thì đó là làm cho bệnh nhân gây hại hơn.
Yeah, great point. So the people I'm doing this on cannot have sex, so I'm not going to make them worse. Is kind of the main thing, because these are people that can't put anything inside. So I usually set the expectation. We know that the data shows that 80 to 90% get better. And so I do tell my patients, that there might be some, and I've had this happen where there's one little area of pain along the incision line, but overall, and I do these all the time, the pain everywhere else is so much better. There will absolutely be scar tissue. And so the way to prevent the scar tissue is by introducing dilators at about 6 weeks. And they have to do it. If they don't do it, I have seen this, because they're like, oh, you did surgery, you fixed me. And I'll see them 6 weeks later, and I can't believe I can touch them. It's such a satisfying surgery. I'm like, oh my God, I can touch you. The only thing that hurts is a little bit along the suture line, but then I see them 3 months later, and all their pain is back. Because now it's just a big scar, and everything is tight. So the surgery does not fix it, it's the surgery and then physical therapy. But it is a process. And so I tell people, that they're going to have to make an investment, and you can't really know for about 6 to 12 months how successful it is. But I just recently was checking, I always check in on my patients to see how they're doing after the surgery. And one just wrote me yesterday saying, she's in physical therapy, she's working her way to larger dilator size, and it still hurts a little bit, but it is night and day difference. Right now it's tight, it's not like a stabbing, burning pain, and they have hope. And so it's really, if you do the surgery well, like I said, close all the spaces very well, it's pretty unlikely you're going to end up with like a dehiscence or a scar opening or getting much worse. Great question.
I just want to hear how you talk to women about pain, because what I think is so difficult is that women expect to have have pain when they have sex sometimes? I see so many patients that are told that when you have your first intercourse, you will have pain. And it's a kind of like also a cultural belief that women have pain, and then they continue having sex with pain, and then they got more pain, and then they get afraid of the pain, and then they contract their pelvic floor. So I just want to bring out that it's so strange with women and pain, because somehow they expect to have it and they also accept it. And I think it's so important that we educate about, no, you shouldn't have sex when you have pain because it's going to make it worse. But then they stop having sex, so that's the other problem. So how do you educate? What do you talk to your women about?
That's a great question. I oftentimes will see people who are told, so the big thing, there's so many things this brings up, right? This is the people with low desire. I think we oftentimes are like, oh, I don't want to have sex. And you have to ask, well, does it hurt to have sex? And they'll be like, well, yeah, of course it does. And I'm like, but they'll be like, can you give me a medication to make me want to have sex? And I'm like, there is no medication that's going to overpower what the brain does when something hurts, right? When something hurts, you do not want it. So we usually say sex can hurt the first time, but it should not hurt after that. And if it does, we need to talk about what may be the cause. And so I actually don't tell people to expect it, and I see those patients who are like, well, it's always going to hurt. And so it's exactly as you said, and they develop pelvic floor dysfunction and anxiety, and then they have low desire, and now we're basically addressing every sexual dysfunction, where if we had just stopped from the beginning and said, hey, if it kept hurting, let's end it. The one place I see this a little differently, and I'm not going to talk too much about pregnancy and postpartum. Dr. Alcock will, and he may see it differently in postpartum. Because postpartum, if somebody has a tear, it will almost always hurt when they start having sex again. And I hate to tell people to just work through the pain, but honestly, the more sex they have, the pain will start to hurt less. And that's just part of an obstetric injury. And so, if they can have access to physical therapy, they'll usually have them with lidocaine or various things, because they need to just reopen the tissues if they have an obstetric injury. So that's one example. So I hope that answers your question. Because I do think some people expect it, but the other thing I wanted to address is sometimes people don't come to me saying that they have sexual pain, but when I do a pelvic exam for something else, the speculum hurts them so much. And that is a clue for me to say, hey, does sex hurt? And they'll be like, well, yeah, it does, but it's supposed to hurt. And then it opens a whole door to kind of helping figure out why are they having pain. Now, speculums are uncomfortable, right? But if it really hurts to go in, that's a really good opportunity to say, gee, you also have pain with sex. And then we start from this little, the whole algorithm to begin with. So now you're finding those patients rather than them finding you. Question?
Dạ, tôi có một cái tham luận và cái chia sẻ và một câu hỏi câu thứ nhất á, thì thực ra là cô nói có vấn đề nếu mà đau khi giao hợp á, thì có sử dụng cái lidocaine, nhưng mà lidocaine ở Việt Nam thì tôi tìm không thấy, mà có kinh nghiệm của tôi thì có xài silocaine mà gel á, thì bôi cũng có, thực ra đúng là hiệu quả tuyệt vời. Cái bệnh nhân mà khi bệnh nhân đó là nói lại thì là tuyệt vời, và cái này kinh nghiệm từ bà xã của tôi ngồi ở hội trường này, bà xã tôi chỉ cho tôi chứ không phải là tôi lúc đầu cũng không biết, nhưng sau đó biết tôi không biết. Đó là cái thứ nhất. Cái thứ hai nữa đó là nói thật sự đó thì vì cô cũng là một giáo sư về phụ khoa, thì tôi muốn hỏi thật sự, vì nếu ai ở đây là bác sĩ phụ khoa cũng biết đó, là bệnh lạc mà cái cung là một cái bệnh mà gây đau vùng chậu rất là nhiều, mà cũng đau khi giao hợp. Và cách điều trị của cô nói đó thì đầu tiên chúng ta có thể sử dụng như thuốc ngừa thai phối hợp, chúng ta có thể sử dụng progestin, chúng ta có thể sử dụng Dinojet. Ví dụ như giả sử như sử dụng Dinojet thì giảm đau được 80%, nhưng trong đó có 30% là nó có thể bị đông kinh đông huyết, cũng ảnh hưởng đến vấn đề của quan hệ. Và nên nhớ rằng bệnh lạc mãn cung là một cái bệnh có thể lan ra những xung quanh và tất cả nhiều cơ quan nữa, chứ không phải là ở một chỗ đó, thì cái cắt tử cung cũng không thể giải quyết được vấn đề đau. khi giao hợp. Và những cái phương pháp khác, ví dụ như bây giờ chúng ta đặt cái bọc DNA hay chúng ta sử dụng cái GH bằng vận đối vận vân vân, thì nó làm giảm cái lượng nội tiết đó, cũng không thể khô cái âm đạo như này, làm giao hợp cũng khó. Thì tôi muốn hỏi câu hỏi thật sự, bởi vì hôm nay chúng ta nói về cái rối loạn tình dục của phụ nữ, như vậy thì cái bệnh đó nó điều trị như thế nào? Thậm chí tới thời điểm này cũng không biết cách điều trị nào nó hiệu quả. Vậy làm sao giải quyết được vấn đề rối loạn tình dục của phụ nữ? Thực ra đó là cái vấn đề nan giải của phụ nữ hiện tại mà phụ nữ phải chịu. Cảm ơn.
So I think the question is about kind of endometriosis or other types of gynecology. There's many things in gynecology that we use hormones to treat, right? Heavy bleeding, endometriosis, irregular periods. We give people hormones to treat those, but I just explained that those hormones oftentimes can cause other problems, right? They can cause FST, they cause lower testosterone, and I think this is like a lot of what we do in medicine is a balance of risks and benefits. If somebody has so endometriosis, not all people with severe pain have endometriosis. And so I always, we sometimes make the assumption that they do, but if they have severe endometriosis, it can cause infertility. As you said, it goes to all kinds of organs. So we do need to consider using these hormones, and as I said, not everybody that uses like Dynagest or Depo-Provera gets vestibulodynia. Not everybody. It's actually just a small percentage. Think about all the people that are on these hormones. Not all of them are getting sexual pain, right? But for those that are, this is where we start thinking about, are there other alternatives? And as I said, something that is just a progestin-only pill. Do you guys have norethindrone acetate here? Agestin? Is that a pill that you guys have? I know Dynagest. But you may have, so things without estrogen components, if possible. Progesterone-only pills we use. Do you have levonorgestrel IUDs? Yeah, so levonorgestrel IUDs are great. They don't cause that kind of pain. So thinking of alternatives for some people, if they're having a side effect to Dynagest or some of the other systemic medications, if possible. And then obviously, as you said, keeping in mind that there's only so much you can do for the endometriosis. If someone also has pelvic floor dysfunction, you have to treat it. And that's why doing that exam, right? Not just assuming that it's the endometriosis, but saying, are the muscles also tender? Do I need to do physical therapy? Do I need to inject the muscles? Do I need to do something? Because endometriosis can cause problems in so many places. So I'm not sure I see it as a debate, as more of an agreement that we have. And I think of things through the lens of a sexual medicine provider, but I also am a general gynecologist. So I see people with these problems all the time, and I have to get creative for how I preserve their sexual health as well as their gynecologic health. And sometimes those things are a little bit at odds with each other. Yeah.
Okay, so I just want to add the comment because we had a question before about the multidisciplinary approach, because that's a very complicated patient maybe, and from my point of view, we would then talk to people about maybe you need to have some sex that doesn't have intercourse. So try to help people having other satisfying sexual life for a while and not focusing so much on the intercourse because now it's giving so much pain. So instead of saying now we stop doing everything, they just stop having intercourse and then they do something else and stimulate each other in other ways. And then you can treat the gynecological problem. So that's where we talk about the multidisciplinary approach, that we can also, people are so focused on the intercourse, but maybe they can do something that's very satisfying, not having intercourse, but still having intimacy in a sexual life. So I think it goes from a patient that has maybe one problem and then they have 2 or 3 problems. So we need to have many different aspects in treating these patients.
Another question?
To comment, so also to think that every patient is a special patient. So we have to make a tailored approach, a multidisciplinary and tailored approach. So you have to consider different therapy in a different patient, but also during her life, it should change the way you manage. So I mean, if it is the most important thing is to have a baby and to recover fertility and so on. So you change also the therapy during the long-term approach. So I mean, it's a difficult task, but whenever we discuss together and we find the best solution for this patient in this part of our life, maybe it's the best approach.
Last question or more questions?
Vâng, cảm ơn một quan trình bày rất hay. Ở đây cảm ơn cô bác sĩ phụ khoa và tôi thấy rất nhiều bác sĩ phụ khoa mà để nói một cái bài bất thường phụ khoa liên quan đến về rối loạn tình dục nữ thì nó rất là khó vì nó quá nhiều, từ nội tiết cho đến nhiễm trùng đến bất thường thực thể bệnh lý lạc nội mạc tử cung. Cho nên là để mà trong thời gian ngắn như vậy chắc cô cũng có thể trình bày đầy đủ được. Tôi cũng rất là đồng tình với một cách tổng quan của cô. Chỉ có một vài ý kiến như thế này, chúng ta có cái rối loạn tình dục nữ thì nó rối loạn từ cái ham muốn, cái ham muốn và ham muốn bản chất, ham muốn tiếp xúc, ham muốn cái sau đó mới đến hứng phấn. Thì khi mà mình muốn tiếp cận cái bất thường thực thể đó, mình hỏi thực tế chúng tôi hỏi cái ham muốn, nếu có cái ham muốn thật sự thì cái đó là mình sẽ bắt đầu nghĩ đến những cái vấn đề thực thể. Cái ham muốn này chủ yếu nó ảnh hưởng bởi cái nội tiết của chính nó. Còn những vấn đề mà không liên quan đến ham muốn thì khi đó chúng ta sẽ tìm theo hướng khác. Khi có ham muốn, nếu những cái vấn đề ví dụ như cô trình bày tại trung ấm hồ, nó có những cái bệnh lý từ lichen đến viêm nhiễm và cả cái bệnh lý từ viêm nhiễm siêu cấp viêm nhiễm siêu cao thì chúng ta sẽ tiếp tục tìm kiếm các cái vấn đề bất thường thực thể như vậy. Có hai ý kiến cũng xin trao đổi với cô liên quan đến cái bất thường. Cái thứ nhất là cái chuyện sinh đẻ, bản chất là những cái đẻ của mình nó sẽ làm ảnh hưởng cái hệ cơ quan sản chậu rất là nhiều và các tầng sinh môn. Vì hai cái chuyện này ấy, nếu mà mình gặp tình huống liên quan đến sinh đẻ nhiều và các khâu tầng sinh môn thì cái can thiệp sẽ như thế nào? Hẳn đơn thuần là như cái khâu ở âm hồ như cô trình bày. Cái thứ hai là cái vấn đề viêm nhiễm đó, cái viêm nhiễm sinh dục thấp thì hay gặp là cái viêm bắt đầu có đặc hiệu bacterial vaginosis. Chứ còn cái chuyện viêm mà do nấm hay là do các cái pet rồi thì cái chuyện nó quá rầm rộ khi mà đang được tập trung hai quan hệ. Và khi những cái trường hợp mà viêm âm đạo không đặc hiệu đó, thì nó BV nó mới là thường gặp và ảnh hưởng nhiều đến cái tình dục. Còn cái viêm mà sinh dục cao, viêm phần phụ hoàn tử thì không phải gì để mình chẩn đoán. Mình học lý thuyết là vậy thôi, chứ không mình nói để mà hỏi để mình nghĩ ra được phương án là sẽ xác định cái bệnh cái dấu viêm phần phụ thì cái này thì nếu có được thì cô có thể chia sẻ thêm cái kinh nghiệm. Bởi vì thực tế đối với bệnh nhân vô sinh thì chúng ta đi rất là kỳ, nhưng bệnh nhân phụ khoa thì không phải khi nào cũng có thể sản xuất được cái trường hợp mà viêm màng không phải là để cấp.
No, I understand. I mean, I have to think here. So this is a great segue into my next talk, which is going to be on common gynecologic and obstetric conditions related to sexual health. And I think it may be, we may want to move on just in the interest of time, but what I will say is I really appreciate that, the most common sexual dysfunction is low sexual desire. And we had a really good talk on this earlier. I think that, my talk was really focused on sexual pain. Where I see those overlap significantly, the main place that I really want to make sure people take away from this is that whenever you're evaluating someone for low desire, do not miss whether or not they have sexual pain. And that the first treatment that I will do, and from the medical perspective, I appreciate the mental health perspective here, is I target the pain, right? So if I have a postmenopausal woman who wants testosterone because she's got low sexual desire, but she also has GSM and significant pain with sex, I treat the GSM and pain with sex before I would give her something like testosterone. Because I need to make sure she can have pain-free sex before I give her something psychologically that would make her want to have sex. Because say I give her the testosterone for a few weeks and she's like, oh, my desire goes up, let's have sex, and then the sex hurts. That's going to completely shut down the neurotransmitters of desire, right? And so it's that idea of that tipping point, right? Things make us want to have sex, and things make us not want to have sex. And the inhibition, the things that make us not want to have sex, I think are stronger. And so I target those first. And I think that what I would, just in response, that I think there are some infections, so recurrent EB can be uncomfortable, obviously. Recurrent yeast infections obviously cause pain and burning. However, in my experience, I think I oftentimes see those get overdiagnosed as the cause for sexual pain. And especially things like yeast and BV, because we know that patients that have vestibulodynia, so secondary vestibulodynia, I didn't give that case example here, but somebody comes in and says, I keep getting yeast infections, I'm getting treated over and over again. Oftentimes we'll do a culture and we don't find yeast. I look at it under a microscope, I don't find yeast. But they say it still burns and it hurts and I can't have sex. Well, it's not a yeast infection, it's actually vestibulodynia now, and there's actually good basic science data that shows that an initial infection, a UTI, a yeast infection, BV, triggers inflammation in the skin and causes it to hurt, but it's not an ongoing chronic infection. It's now an inflammatory response of the skin, and we need to treat it not as an infection. And so there's actually